Warning: please do not use or derive concepts from this video to try answering questions and incorporating it into the diagnostic approach to a patient. Hello! This video is brought to you by Animoma. In today's mini lecture, we will be discussing Wario's hyperflatulence, also known as his Waft attack. First, we will discuss air pressure building up in Wario. The air pressure may build up with a similar mechanism to hyperlactose intolerance, where a compound is unable to be absorbed, which then allows bacteria to undergo hyperfermentation to form excessive gas. Another theory that's much more plausible would be that he has a voluntary colonic contraction ability and can cause gas to build up. And one last theory is he may have a functional fistula between the respiratory tract and the colon that allows him to accumulate gas for the Waft attack. The air pressure builds up, which increases the likelihood of diverticulosis, which may stretch and damage the intestinal wall, leading to diverticulitis, in turn leading to perforations and fistulas. A fiber diet may be recommended for soft signs of diverticulitis and surgery for hard signs. Air pressure in front of the fecal matter can cause constipation or fecal impaction, which may require manual removal. Sometimes constipation can exert pressure on the bladder, obstructing flow and leading to UTIs. Adaptation for megaintestines may be through abdominal hyperextendability, also referred to as abdominal Ehlers-Danlos, where the skin and other organs are easily able to stretch and compress. This may leave stretch marks. You may prescribe topical ointment if the patient desires an aesthetic appeal, which, as we know, is a top priority for Wario. If the air leaks out, it may cause abdominal compartment syndrome. If you want more depth on compartment syndrome, check the section on my Attack on Titan lecture. So now we will discuss Wario's Waft syndrome, which stands for worrisome airflow tension syndrome. It is X-linked. The test makers may give a hint by stating the patient is a male. It has to be differentiated from other diseases such as a malrotation, ileus, megacolon, bacterial overgrowth, bowel obstruction, and superior mesenteric artery syndrome. It is differentiated from malrotation, which usually occurs in babies. One worrisome complication is a volvulus. On imaging, you may see a whirlpool sign with a midgut volvulus. A sigmoid volvulus can be diagnosed and treated with a sigmoidoscopy and presents with coffee bean sign, but a cecal volvulus is much more severe and always requires surgical correction. It can present like an ileus, but an ileus is milder and doesn't present as severe in an abrupt onset. You won't see the signs of infection or inflammation as is in the case of a megacolon. It may occur in conjunction with bacterial overgrowth, which would indicate a severe variant of the Waft disease. One way to look for intestinal bacterial overgrowth is to measure levels and symptoms of vitamin and mineral deficiencies such as B12, iron, calcium, etc. To differentiate from bowel obstruction, you will hear a loud blowing murmur and then a dub at the obstruction site, as opposed to in a bowel obstruction, you will hear hyperactive bowel sounds initially and then hypoactive bowel sounds later in the disease. Since the superior mesenteric artery is really long, abdominal pain can occur at many locations throughout the intestine, similar to Waft syndrome. However, rather than being associated with an obese individual, superior mesenteric artery syndrome may be associated with decreased mesenteric fat due to rapid weight loss, which causes the superior mesenteric artery to compress the third portion of the duodenum. Signs and symptoms include early satiety, nausea, vomiting, extreme stabbing, postprandial abdominal pain, which is due to duodenal compression and the compensatory reverse peristalsis. It's also associated with abdominal distension or distortion, burping, external hypersensitivity or tenderness of the abdominal area, reflux, and heartburn. In some cases, superior mesenteric artery syndrome is associated with severe malnutrition accompanying spontaneous wasting. This in turn increases the duodenal compression, which worsens the underlying cause, creating a cycle of worsening symptoms. For many, symptoms are partially relieved when the left lateral decubitus or knee to chest or in the prone position. A Hayes maneuver, which corresponds to applying pressure below the umbilicus in the cephalad or dorsal direction, elevates the root of the superior mesenteric artery, also slightly easing the constriction. Symptoms can be aggravated when leaning to the right or taking a face-up position. Females from 15 to 30 are more commonly affected as opposed to the X-linked male Waft syndrome. So now we will discuss the anomalous voluntary dual sphincter mutation that may be associated with Waft syndrome. This mutation rarely exceeds one extra sphincter. Patients most of the time have voluntary control over the sphincter. It usually opens up with the normal rectal sphincter. For this portion, we shall migrate to the whiteboard. There are three lengths of the sphincter. The longer the sphincter, the more severe the symptoms. There's three lengths. The three lengths are mild length, a moderate length, and a severe length. These sphincters can be unilateral but are more commonly bilateral. The mild length and the moderate length usually attach adjacently, whereas the severe length attach across the whole lumen. Most of the time, these type of sphincters are considered similar to adhesions and self-resolve due to force breaking them, and then they get sloughed off by colonic contractions or elevated pressures. The depth of the sphincter is a stronger indicator of the severity of the disease. If it covers up the whole lumen, it can present similar to an obstruction. The most likely areas that can get damaged from the buildup of pressure are the watershed areas, such as the splenic flexure and the sigmoid colon. The lower down the sphincter is, the more gas can accumulate, but it may be easier to treat due to easy access of applying botulinum injection or another muscle relaxant, which would increase the likelihood of the sphincter self-sloughing itself. The rest of this slide just reiterates what I said, so now we will move along. Finally, we will discuss the treatment plan. For the most part, this is a benign condition. We recommend weight loss through exercise and diet. We may also recommend an increased fiber diet to prevent diverticulitis symptoms. Additional therapy may include abdominal negative vacuum therapy weekly to monthly, depending on the severity. A botulinum injection or muscle relaxant cream may be recommended to release secondary sphincter tension if possible. The patient should avoid tight clothing or strenuous activity to avoid pressure buildup. For more severe symptoms, we may recommend NPO, nasogastric decompression, parenteral nutrition, IV antibiotics if we suspect bacterial overgrowth or sepsis. For even more severe symptoms, we may recommend a sphincterectomy with a colostomy. Rarely do we need to perform a complete bowel resection. Thank you for watching my medical fiction analysis. Please watch my other videos, and don't forget to like, comment, and subscribe below.